Dear audience, let me present my PhD topic regarding the improvement of acute pancreatitis management. My name is Dorottya Tarján, and I'm a gastroenterology resident and a PhD student at the Center of TM. My supervisors are Alexandra Mikó and Péter Hegyi, and my SMS is Eszter Szalai. My mission is to improve the management of acute pancreatitis. To achieve this, I have 3 specific goals. The first one is to identify early predictors for infected necrosis in acute pancreatitis, and for that I'm conducting a systematic review and a meta-analysis. My second topic is about investigating the safety and effectiveness of cholecystectomy in pregnant women with acute pancreatitis. For that, I'm conducting a register analysis and an international survey. My third project was a perspective article with 3 case reports regarding the use of artificial intelligence for severity prediction in cases of acute pancreatitis. So first off, let me talk a little bit more about my first topic, which is identifying early predictors for infected necrosis in acute pancreatitis. Among acute pancreatitis, 20% of patients develop necrotizing pancreatitis, and 30% of patients will be diagnosed with infection. Secondary infection of the necrotic tissue is a severe condition with increased morbidity and mortality, requiring antibiotic treatment or even invasive interventions. The risk of organ failure is 3 times higher, and the risk of mortality is 2 times higher compared to sterile necrosis. However, early predictors allowing the initiation of an early therapy to improve the outcome have not been established yet. Therefore, our aim is to identify these early predictors. To answer this clinical question, we included studies that measured any laboratory parameters between the 2 subgroups. We selected studies that confirmed infection by CT imaging with the presence of gas in the necrotic collection or by examination of the sample acquired by intervention using gram staining or a culture. Our main interest was the presence of infection. We conducted a systematic search and selection at last year, October, in the 3 major databases with the search key as you can see below. In the end, we got 14 eligible studies and 9 eligible studies for the meta-analysis, approximately with 800 patients. I would like to show you my first forest plot for the AUC of the CRP. To understand this forest plot, first I want to talk a little bit about the area under the curve. If the AUC is 0.5, it means that our prediction is like flipping a coin. We have a 50% chance to be correct. However, if the AUC is 1, we can be sure that our estimation is 100% correct. As you can see here, in the early phase of the disease, within the first 3 days after admission to the ward, the AUC is only 0.69, which means it has a poor predictive value for the prediction of infection. However, in the late phase, after the first 3 days, the AUC was 0.88, which means it has a good predictive value. In the next forest plot, for the procalcitonin, we got similar results, as you can see. In the early phase, the AUC was also 0.69, and in the late phase, it was also 0.86. In case of the white blood cell count, in the early phase, the AUC was only 0.61, which means it has a really poor predictive value. The strength of my meta-analysis is that this is the first one which includes subgroup analysis based on different time intervals, and there was no significant heterogeneity in the subgroups. The limitation is that we only find some small number of observational studies without any follow-up periods. In conclusion, in the first 3 days, the serum measurements of CRP and procalcitonin could be elevated without the presence of infection. However, if they stay elevated in the late phase, it could be associated with infection and it can guide antibiotic therapy. In the future, we are needing for more studies with longer follow-up periods, and there is a need for a scoring system which involves laboratory parameters and clinical parameters as well. As you can see for the manuscript, I'm currently sending it to my supervisor, and in the end of August, I will send it to an internal review. My second topic is investigating the safety and effectiveness of cholecystectomy in pregnant patients with acute pancreatitis. Acute pancreatitis in pregnancy refers to acute pancreatitis that occurs during pregnancy or 3 months after delivery. While most cases are mild, resolving within 2 days, 20% of the cases will be severe. The most common cause is cholelithiasis, and acute biliary pancreatitis related to pregnancy has a relatively high recurrence rate as 70% compared to the general population. In the general population, by randomized controlled trials, such as like the PONCHO trial, it had been shown that early cholecystectomy has multiple benefits in case of it will reduce the rate of recurrent acute pancreatitis and other biliary complications. However, currently no guideline to how to manage pregnant patients after the episode of acute pancreatitis, whether we should recommend them to go through this elective surgery. However, there are some recommendations that people will benefit this surgery, since after appendectomy, cholecystectomy is the second most prevalent procedure, and it has been shown to reduce the rate of hospitalization and emergency department visit, and also in cases that went through cholecystectomy, the preterm birth rate improved. So our aim is to investigate the safety and effectiveness of index cholecystectomy in pregnant women. To answer this clinical question, we want to compare index cholecystectomy with no index cholecystectomy, and our main outcome of interest is the need of neonatal intensive care unit, the rate of mortality, the rate of preterm births, the recurrence rate, and the severity rate of acute pancreatitis. Our hypothesis is that index cholecystectomy is safe and reduces the recurrence rate of biliary acute pancreatitis and improves the outcomes as well as for the baby. So the survey is currently sent out to 35 participating centers. For 18 centers already sent back their data set. In 4 centers, the ethical approval is still ongoing. So finally, my third project, which is acute pancreatitis severity prediction, is time to use artificial intelligence. This is a perspective article with case reports. The course of acute pancreatitis can be very variable depending on the severity of the disease. Therefore, early risk stratification are really important. To that, we have 3 options. The first one is univariate biomarkers such as the CRP, creatinine. Their main disadvantage is that they have low accuracy. The next step are the use to multivariate score systems, such as the Bishop score or the Apache score. They have 2 main disadvantages. The first one is they often require not routinely measured laboratory parameters, and they often require more time to be able to fulfill. And our third option is the use of artificial intelligence. The easy application is the first web-based application, which uses machine learning model to give us a calculated risk score between 0 and 1. It uses multiple continuous variables, therefore there is no information loss. And since it uses artificial intelligence machine learning model, it is continuously improving, there is no information loss, and it can be used early at the time of the admission. And it was published last year, December, in a Journal of Clinical Medicine. To give you some summary of my projects, the first one I'm currently planned to send to internal review at the end of the summer. The second one I'm currently working for the preliminary data table for the statistician, and the third one was published in December. Thank you for your attention, and let me finish with a quote: "Hope is the thing with feathers."
So thank you for your excellent presentation. I would like to ask about your second project that. What are the most important adverse events that you expect from this study?
So the most important adverse events is preterm delivery, the death of the baby, and like complication for early preterm birth, which after that the baby still requires neonatal intensive care units. I think we want to detect our main disadvantages. We want to estimate which has a bigger risk factor if the patient has another episode of acute pancreatitis, which they has a really big chance, or if better to go through surgery, which is an invasive procedure, which also can have like major disadvantages, can maybe induce birth. This is what we want to investigate with this study.
Regarding your first project, have you thought of checking the dynamism of these different biomarkers? Maybe it gives you more relevant answers than the absolute values. Day-by-day changes would predict better the infection or earlier the infection than the absolute values.
Yes, you are correct. So we concluded like the pooled AUC data from these studies, and they often measured to get this data multiple days for these parameters. That, for example, in the longer period, they actually measured like for 2 weeks every day for the laboratory data, and they said that in this period of time, the AUC was 0.86, and we pulled their data. So it's basically a multiple data, not just one data that they measured, but you are correct. The dynamic can also tell us really a lot about these patients.
For your second project, you gathering data which is reported to you by someone as pooled data, or do you have access to raw data from each individual patient?
I sent out an Excel sheet, and there is every row is a new patient. So it's
basically you get the raw data, which is
yes,
retrospectively collected for each patient, and then you will be able to see what happens to the ones who are operated before birth.
Yes.
And the ones who
don't
get operated
yes.
before the birth of the baby. That's interesting. How many patients do you have already?
Around 100.
That's good.
Yeah.
What is the largest case series reported so far? Has there been any case series reported in this topic? Multiple cases reported in the literature in this exact same topic?
It's hard to say because they usually see retrospective data, but it's not as specific. So they look for the diagnosis of which patients had biliary acute pancreatitis, and they're usually not very detailed articles. But the most one is like 1,000 patients.
Okay.
I would like to ask a question. What was, regarding your third project, what was the difference when you assessed the outcomes? What was the difference of accuracy when you assessed it with multiple variables compared with AI? So what's the additive effect of using AI in the early prediction of the severity?
I think the most beneficial part of it that it also includes a lot of clinical parameters like blood pressure and heart rate. And because in the Apache score, the main disadvantages was that it also included the second day for the patients. And while the Bishop score, it doesn't really has any parameters because it only has the sepsis score system, which can give us an additional information. So I think the most difference can be in patients who have an early, like fulminant pancreatitis. The EasyApp is more specific to that kind of disease progression.